Hello, Mike.
Oh, there we go. Hi, how are you?
How are you?
Good, good.
Good. Just getting everything. Give everyone a minute to. Okay, we'll go ahead and get started. Good afternoon and welcome to the summer 2022 meeting of the Human Services Advocacy Network, or HSAN. My name is William Tarter Jr. and I'm a fellow at the Center for Community Solutions. A few housekeeping notes. Please keep your microphones on mute. This forum is being recorded and a copy of the recording will be available on the Community Solutions website. The hashtag for today's event is #HSAN. Questions can be submitted in the chat box and we will try and work some of those questions into the program. Today's conversation is focused on the Cuyahoga County Diversion Center. Opened in May 2021, the Diversion Center is operated on East 55th Street in Oriana House under a contract awarded to the Adams Board. Central part of the conversation about the intersection of behavioral health and the criminal justice system in Cuyahoga County. Now open for about a year, Center for Community Solutions has invited a number of experts with a variety of backgrounds and expertise to discuss the origins of the center, the operations, and how it fits into future conversations about mental health and the criminal justice service system in the future of Cuyahoga County. Rest assured, the conversations today will not be the final conversation on this very important subject. Our panelists today are Dr. Megan Testa from University Hospitals, Brandy Carney from Cuyahoga County, Mike Randle from Oriana House, Donna Weinberger from the Greater Cleveland Congregations, and our moderator is Joan Englund. Dr. Megan Testa graduated from Case Western Reserve University School of Medicine in 2007 and subsequently completed a residency in psychiatry at University Hospitals in Cleveland, followed by fellowships in forensic psychiatry and community psychiatry at Case Western Reserve University. Dr. Testa is currently an assistant professor at University Hospitals and Case Western Reserve University. She spends her clinical time providing psychiatric care to individuals with severe and persistent mental illness, addictions, and criminal justice involvement at Frontline Services, a community mental health agency in Cleveland. Center. She provides forensic consultation at North Coast Behavioral Healthcare and the Cleveland Municipal Court Psychiatric Clinic. She serves on the Cleveland Community Police Commission. Welcome, Dr. Testa. Brandy Carney currently serves as the Cuyahoga County Public Safety and Justice Director, a position she initially held in June 2016. While she has maintained her director responsibilities, she also assumed additional roles and responsibilities throughout these years, including an 18-month additional responsibility for the Cuyahoga County Sheriff's Office, including corrections, the medical examiner's office, clerk of courts, and consumer affairs. Additionally, she held a special projects temporary 2-year position, which also included the management and responsibility for the Cuyahoga County Opioid Fund and its associated projects, including the planning, implementing, and sustainment of the first of its kind diversion center in the state, the Cuyahoga County Diversion Center. Welcome, Director Carney. Oriana House Executive Vice President of Operations, Mike Randle's career in corrections spans over 30 years, with nearly 20 years at the Ohio Department of Rehabilitation and Correction, where he served in a variety of positions, including mental health administrator, warden, deputy director of business administration, and assistant director for the agency. Mike was appointed director of the Illinois Department of Correction, serving under Governor Pat Quinn. Mike returned to Ohio in 2010 to work for Oriana House Incorporated, first as the program manager of the Cuyahoga County Community-Based Correctional Facility, and most recently as the Regional Vice President of Correctional Programming in Summit County. As Executive Vice President of Operations, Mike is responsible for the overall operation and management of residential, non-residential, and diversionary community corrections programs, including cognitive skills, treatment, employment, and education programming. Welcome, Mike. Donna Weinberger is a mental health therapist in the community and a leader at the Greater Cleveland Congregations, where she has successfully led action teams on Medicaid expansion, gun violence reduction, and criminal justice reform. Donna led GCC's 4-year fight to bring the Diversion Center to Cuyahoga County, the first of its kind in the state. She has served as president of the Ohio Clinical Social Work Society and currently serves on the advisory board of the Diversion Center and the Mental Health Response Advisory Committee related to the consent decree. Donna is also on the independent review panel for the Cuyahoga County Conviction Integrity Unit. Welcome, Donna. And finally, our moderator is Joan Englund, Executive Director of the Mental Health and Addiction Advocacy Coalition, or the MHAC, and has served in that position since February 2003. The MHAC is comprised of over 130 organizations around the state of Ohio, including behavioral health agencies serving both adults and children, health and human services agencies, the faith-based community, government and advocacy organizations, major medical institutions, and the corporate arena. The MHAC fosters education and awareness of mental health and addiction issues while advocating for public bodies and policies and strategies that support effective, well-funded services, systems, and supports for those in need, resulting in stronger Ohio communities. It is now my pleasure to turn the event over to the moderator of today's discussion, Joan Englund. Joan?
Thanks, Will. Appreciate that. Appreciate you, and thanks for introducing our wonderful panel. This is a really important conversation today, and we're so glad to be hosting it, but also that so many of you have joined us. So thank you for this conversation. We have dedicated about 35 minutes for our panel to speak today. So we're gonna jump right in with this important conversation. So let's get started. Brandy, can you give us a brief background on the history of the Diversion Center? How do we get to where we are?
Sure, I'd be happy to. And thank you for having me as part of this discussion. Also, this is really great to continue to get the word out, and very happy with all the panelists. So thank you. So I think Donna had mentioned her 4-year fight, and approximately 4 years ago, maybe 5, there was a number of individuals that started down this path. GCC was extremely integral to this process, starting this process, making awareness to the Prosecutor O'Malley at that time, about alternatives to incarceration, and particularly diversion centers. There's a continuum that groups such as Metro Hospital Leadership and GCC Adams Board that started to meet to identify and prioritize these opportunities rather than incarcerations. Additionally, at the county here, we had a law director, Bob Triazzi, that felt really strongly and passionate about this cause also. So it was lucky enough to be one of those initiatives that there was truly widespread support from. There's been some challenges, but there was a lot of support for this idea. You know, the county has also, we knew we would probably be going down the path for a new jail at some time soon. And a new jail, you have to identify how big you're going to make that jail and how many beds. So it was really a key time. If there's not opportunities for diversion and programming that takes people out of the jail and treats needs differently as they should. If there was ever a time that it hadn't begun, it was really now to start doing that. So we didn't go down the process of an expensive jail and maybe overbuild it in beds because we didn't have other options. So this 4-year process really had a lot of support. To keep things, for the sake of brevity, I'll say, you know, there was a number of meetings and we really had great representation from nonprofit, government, for-profit, supporting this idea of opening up a diversion center. Again, in lieu of incarceration was really the big reason that a lot of the discussion started. And we were lucky enough to have a consultant that the county hired, Pulitzer and Bogart, who has worked on other successful diversion centers, such as Bexar County in Texas. And so they brought a lot of good expertise to the table. And myself and chief of staff from the county, all of you were part of this process, or most of you were. And so we were able to pretty quickly, in my eyes, as a county employee, get a diversion center open with all the people on this panel and others in May of 21. That was a quick overview of those years.
Yeah, great. That was good, Brandy, the down and the dirties. We appreciate it. Also want to lift up the role of the Adams Board in all of this, and the former CEO of the Adams Board, who we know just recently passed, Bill Danahan, was a staunch advocate for this as well. So,
Absolutely, that's a huge one. So thank you.
Absolutely. So all right, with that background and that groundwork laid, Mike, with Oriana House, and you're involved on the day-to-days at the Diversion Center, can you give us the basics of the Diversion Centers, kind of the logistics side of things, the who, what, when, where type thing? And then when you're done, we're going to flip it over to Dr. Testa, who's going to talk about the services that are actually available at the Diversion Center. So Mike, can you start us off with that?
Sure, Joan. As was mentioned, the Diversion Center did open May 1st. And the most important part of opening up the Diversion Center was that it's meant to be part of the current continuum of services that are being offered. And from an operational standpoint, everything starts with a phone call to Frontline. Frontline is the triage agency that has access to all of the continuums of services from a behavioral health standpoint that are funded through the Adams Board and the county. And so we wanted the Diversion Center to fit into that existing continuum. And there was a gap where there was a need for this Diversion Center. The second really important operational function of the Diversion Center was to give law enforcement an opportunity when they're on patrol, they come across a situation and a person is in a mental health or substance use disorder crisis, and they may have committed a low-level offense or a low-level nonviolent offense, to have another option rather than taking that person to jail. And the Diversion Center represents that. And the whole structure of how admissions happens at the Diversion Center starts with that Frontline call. If it's law enforcement, Frontline asks a series of questions to determine whether or not the person would be appropriate for the Diversion Center or another level of care. If the Diversion Center is the best option to address that person's crisis needs, Frontline would instruct that officer to transport them to the Diversion Center. While that is occurring, Frontline is notifying the Diversion Center staff that they have a potential arrival from law enforcement, and the staff at the Diversion Center begin to prepare to admit that person. Law enforcement brings that person to the Diversion Center and answers a series of questions from the behavioral health specialists or the nurse that's at the admissions desk, gives us some information, gives us the precinct they're from, their badge number, how to reach them, and then they're able to go back on patrol. The whole idea is to be able to have law enforcement in and out within 5 minutes. And we've been averaging just under 5 minutes throughout the existence of the Diversion Center. It's supposed to be a place where they can come in, answer a few questions, drop the person off, knowing that they will get the help that they need. From there, we have nurses, certified nurse practitioners, LPNs, RNs that conduct assessments. They consult with Dr. Testa on any issues that the person is presenting. If the person needs detox services, there is an area where they can be monitored. Their vitals can be monitored while they go through that process, or if there are other needs that they have. We also begin to work on that person's discharge when they arrive. Our hope is to get the person connected with a service provider in the community within 5 days. We try to have people out of the diversion center within 9 days and connected with a permanent service provider that can provide them with ongoing treatment services or mental health services that they may need. But we are a stabilization unit where we get a person stable, we get them connected. For a lot of this population, they already have received services from community providers. So in a lot of cases, it's a matter of reconnecting them with the agency that they were providing, getting services from. I'll stop there. Thanks.
Thanks, Mike. Just a couple quick follow-up. Is self-referral or friend-family referral available in addition to law enforcement? And what does that go through Frontline too, or how does one do that?
Yes and yes. Right after probably we opened in May, around October, we wanted to fully utilize the diversion center. So we did open up admissions to friends and family. EMS fire can do referrals now to the diversion center, and clients can even self-refer themselves back to the diversion center. So yes, we're accepting all of those referrals, but everything goes through Frontline. And I think that's a critical piece because like I said, there are other levels of care that are higher and lower than what the diversion center provides. But Frontline is the triage that decides based on what the issues are that the person is presenting to get them into the right level of care in Cuyahoga County.
Great, thank you. Is the number that they call, Mike, the number that we see for crisis services and also information and referral? Is that the same number?
That is the same number, yeah.
Okay, great. That sounds wonderful. So we've expanded who can come in. Dr. Testa, can you now talk to us about what services are actually available in the diversion center? And what are you seeing from a behavioral health? And when I say behavioral health, just so we're all on the same page, I mean mental health and substance use disorders together. So talk to us about the services and what are you seeing from a behavioral health perspective and also a physical health perspective with the folks that are presenting and coming to the diversion center?
Of course. So I'll pick up from where Mike left off and kind of explain what we do once someone gets to us. So what we do as a medical team and as a behavioral health team, once someone gets there is whether they're a police referral, a self-referral, a friends and family referral, everybody comes through one door when they get there. And what they come into is our observation area. So when they come to the observation area, they'll meet first with our behavioral health staff, and they'll go through an informed consent process where they learn where they are, what services we provide. We're a voluntary facility, so we need to make sure people can consent to be with us. Sometimes we receive individuals who the police come across them and they're intoxicated. They might need an observation period, so we continue to engage them in the informed consent process. So that can go on in our intake area. What also goes on is our nurses will meet with the people who come in, and they'll do a quick physical health assessment and a quick mental health assessment. Frontline does a lot of screening, but if we remember, they're screening on the phone. So we need to get a sense when we get the person there of a fuller picture. And sometimes we may pick up on individuals who maybe they do need that higher level of care. They might share more or show more symptoms when we see them in person. So we may decide from our intake area that they need a higher level of care than what we can provide. We can ensure that that person will get to an emergency room if that's the case. You mentioned physical health. We see a lot of individuals who have a lot of physical health problems that have not been addressed, either because of their mental health or because they've been homeless or because they've been in their addiction. So if we see physical health issues that need addressed, we can send individuals briefly out to an emergency room for a medical clearance, we call it. So let's get a handle on these medical issues and get some recommendations so that we can handle them in our center or take them back once those issues are addressed. So we can do that as well. And once we know that the person doesn't have any medical needs that need to be assessed and that they're at the right level with their mental health where we can help them, we'll move them through into the center. And at that point, our services would include, we have nurse practitioners on duty 24 hours a day. They can do assessments and they can just provide for the daily check-ins with the individuals. We have clinicians who will assess for any substance use diagnoses that need a referral to treatment. We have nurses 24 hours a day. If someone's in detox, we do have medically assisted detox. So they'll get vital sign checks, they'll get medication to help them with detox. We can get people onto medication assisted treatment, either Vivitrol or Suboxone, and bring them into our outpatient program. So we can do that as well. And then when they identify people who have mental health needs, so serious mental illness is what we refer to that in the program, what will happen is the nurse practitioner will do an initial assessment and see if they're already linked with someone. Do they have a history of diagnoses and medications that they're on? Can we restart those things? And do they need a psychiatric evaluation? If they need a psychiatric evaluation, the nurse practitioners, they'll consult with, there's a physician on call 24/7. They'll consult with me or my colleague. We'll give some initial recommendations and then we'll put them on our list. So when we come through the center on our days that we're there, we can do a full psychiatric consult and help in that way too. We have medications in the center. We have a medication room where we have a pharmacy that'll stock us. But we also have a relationship with a community pharmacy where we can get medications delivered within 24 hours. We also have a very flexible trauma-informed staff, and they can run out and get certain meds if we need things. So we're usually able within, the first day to get someone started in the right direction as far as any medical and psychiatric stabilization. And then, like Mike had mentioned, we're a linkage unit. Like we're not long-term. We're not to just house anyone long-term or really to fix long-term problems. We're to link back with the community so that they can work on those long-term issues. So we really start from day one to link them with the best community agency and the best community social workers, case managers, primary care, finding them a medical home and a psychiatric home.
Very informative. Thank you. A follow-up question for you. I have a million, but I'll limit it to one, and I might actually target it to Mike or both of you. So Dr. Testa, you mentioned that the program is voluntary. So what does that mean? Like the police brought them there, but they can just walk out the door, and what happens then? And what's the theory behind that? Mike, if you want to start, and then
I can start, but I guarantee you Dr. Testa will do a much better job.
You can tag team it then.
Okay. But the idea is one of the goals of the Diversion Center is to develop a relationship with this population. We know people don't stop addiction in most cases the first time. Same thing with mental health. So the goal is to develop a relationship with this population. Maybe the first time you come, we didn't want them to feel like they're being forced by law enforcement to be there. As long as they understand this is voluntary, because we want the person to actually be willing to accept the interventions that the staff that Dr. Testa has been talking about. In a lot of cases, when people feel like they're being forced into treatment, it's not as successful as we would like it to be. That's the first point. The second point is we want people to feel comfortable seeking out this level of care without a law enforcement intervention. We want them to be comfortable seeking out this care before it gets to a point where law enforcement has to get involved. And it's kind of interesting that a lot of people that were originally brought by law enforcement for that first intervention, a month or two later, they find themselves in a crisis situation. They refer themselves back because they knew it was a safe place. They knew it was a place they got treatment and and they were treated in an appropriate manner. And so that's kind of the rationale behind not making this forced. And some do walk out, and I think Dr. Testa, you could probably talk about the AMA process as they leave.
Sure. So our facility, we're simply physically not set up to force anyone to do anything. So while you need to be buzzed in, you can walk out any one of, I think it's numbered 7 doors. So we rely on our motivational interviewing. We're very trauma informed. A lot of the people that we're seeing, they've had a lot of trauma, not just by the criminal justice system, but by the mental health system too. And I say this being a psychiatrist, the system, some people have been forced into care, and they've been pink slipped, and they've been probated, and they've been forced to take medications, they've been given injections, they've been restrained, they've been secluded. So a lot of the people that we're seeing, they've been traumatized by the mental health system. So we just go about doing things a different way. And we're getting really good at engaging people when someone's going to leave. Let's say we have a person, we're totally voluntary, they start telling the staff they want to leave. We really do rally as a staff, and not that we're going to make them stay, we can't, but we want to find out why do they want to leave. And we have a list of goals that as a team, we feel that we've done a successful job if we can meet a number of these goals. So we'll really work with the person and see, like, how can we turn this into what we would call a successful discharge? Like, can we at least make one linkage or do one service or meet one goal that they have? If they're going to walk out anyways, let's make it successful. So that's how we handle walkouts. We, as Mike said, we do have people walk out, and a lot of times they'll end up self-referring back, and sometimes pretty quickly, within a few days, we'll see them come back. They've kind of thought about it, and they've decided to come on back and accept some help. So we just try to make that walkout successful when it does happen. And above all, just treating everyone with respect and showing them a different way to do things than what may be making them fearful of the system itself.
I think that's a really exciting development, that people came there originally with law enforcement and then are presenting subsequently voluntarily, presenting by themselves. That's the trend we hope we had hoped for. And so every time I hear that, I get very excited about that. So we'll keep hoping for even more folks doing that. And that then segues into my next question for you, Donna. We know that since the Diversion Center opened, the numbers are increasing, but they're still not where we had projected and hoped that they would be. We know that the Adams Board is doing a lot of work with law enforcement and the community, educating them about the Diversion Center. But what else is going on to lift up the Diversion Center, what's happening there, and what else could and should we all be collectively doing?
So thanks, Joan. It is important to acknowledge that I think the numbers are lower than the original projections. However, as we think about this, I think it's really important to point out 3 different things when we think about law enforcement drop-off. Number 1, as you said, if you look at the numbers over the span of the last year, they are continuing to increase. Secondly, the center now does, as mentioned, allow admissions by self, friends, and family, something that a number of groups supported. Although those admissions are not initiated by law enforcement, they are real people getting crisis help. And I think that's important. They may be people who actually may have ended up in jail at some future time if they were not provided help then. And thirdly, I think that's really important to point out something that GCC learned when we studied other models throughout the country. And that is that law enforcement diversion is a huge culture change. Officers are very used to taking people to jail. When we looked at the programs in Arizona and Oregon and San Antonio, we were told that it takes 3 to 5 years for that culture change to happen. Now, that all said, I want to say very clearly that we would like to see a lot more jail diversion, especially by the city of Cleveland, particularly from the Cleveland Police Department, because we know that the majority of people in the jail are from Cleveland. I know that the Adams Board has been working very hard on this in terms of getting the word out, increasing CIT training, providing cards that people can use. We also appreciate that the county administration has made a commitment to central booking, which we believe can serve as another intercept point where screening for the diversion center can also occur. But we're still concerned, and we hear anecdotally from our members that there are officers and even commanders who don't know about or support the diversion center. I want to mention that a county analysis, which Brandy gave me, and wanted to give the caveat that it's the best data we can get, which is not great. But their analysis from 2021 revealed that there were 4 people per day sitting in the Cuyahoga County Jail who could have been diverted. And that's a real tragedy, right? To us, for us as GCC, one of the things we are very aware of is that, and I think this is a good thing, the city of Cleveland is at a critical juncture that could make a huge difference. There is a national search right now going on for a chief of police. We think it's crucial that whomever is hired has a real commitment to diversion and even real experience in making these programs work. Because we know that if there is commitment at the top, it will flow down. We believe that Mayor Bibb has a real commitment to the use of the Diversion Center, and we hope this is reflected in the process of hiring a chief and that there is real community input on this issue.
Great, thank you, Donna. Super helpful. So we're talking numbers. Let's keep talking numbers for a minute, not get too wonky, but the numbers can be really informative. So Mike and Dr. Testa, what are you seeing in the numbers? You know, we've had a period of time now. What are the numbers showing? And then a second part of that is kind of the qualitative part of things. What are you hearing from the community, from law enforcement, from individuals that have been through the program? So do the wonky stuff first and then move to the qualitative stuff.
I'll start, Dr. Testa, again. The average has been going up. The average daily number of clients in the Diversion Center has been going up, and it has gone up each time we've expanded the inclusion groups to when we went from just law enforcement to EMS, fire, and then friends and families. Those numbers went up. The Diversion Center itself has a 50-bed capacity. The highest number we've had since we opened in the Diversion Center at a single time is 25 clients. So we were about at half the capacity. These days, we average right around 10 to 12 to 15 or so clients. And you've got to keep in mind that the average length of stay is right around 5 days or so. So that number is sort of a cycle number with an average daily population right around 10 or 12 clients in the building. Some of the things that I think has helped, and I think you all mentioned it earlier, the Adams Board work that they're doing with the training of law enforcement agencies across the county for CIT, but also Brandy has been instrumental in getting other areas of the criminal justice system involved. For example, probation. We are now working with probation to talk to officers about how they refer people to the Diversion Center. They may be conducting a probation visit from a client and notice that a client may be in a mental health or SUD crisis. They have the option of now doing a referral, or at least really soon they will. We also have been reaching out to law enforcement as a diversion center ourselves and going out to individual law enforcement agencies and meeting with them, talking about the Diversion Center. We've hosted several open houses, and we're working now to do more of that. One of the things we want to do is host more opportunities for the Cleveland Police Department for their commanders to be able to come to the Diversion Center. So we continue to work to try to expand and get the word out, because as was mentioned, generally we know this process takes some time for people to get used to utilizing the Diversion Center, but we have to continue to work towards that.
Dr. Testa, would you like to add anything either on the numbers or on what we're hearing from the community, law enforcement, and from the individuals that have been in the Diversion Center?
Sure, I can give you a little feel the type of individuals that we have in. I know Mike knows the numbers a lot more than I do. What I will say is he's right that the stay is so short that in any given week, my colleague and I will have a whole turnover of who's there from one day to the next as we cover and sign out to each other. So we're seeing a whole lot of individuals with mental illnesses. I think a lot more than anyone anticipated when we opened. That's like the biggest portion of individuals that we see and that we help. We are seeing more detox lately and more individuals with substance use, but it's usually what we would call like a dual diagnosis or a mental illness. And when we are seeing these new groups, we're working with probate court. So we've seen a probate court referral. We're working with probation now. We've seen several probation referrals as individuals in the criminal justice system know a little more about us. One week, we got 2 individuals from a GPS station. So they went to have their GPS put on, and the professional who was doing that said, this person is really in a crisis. They're crying, they're displaced from their home because of a protection order. They're not linked with any mental health place. They're new, clean. And so those individuals, we had 2 referrals in 1 week from GPS professionals that said like, wow, this person really isn't doing well. And so we were able to help individuals like that. So I think we're just seeing a wide variety of individuals who are kind of falling in a lot of cracks in the system. So qualitatively, I tell you that is what I'm seeing as a provider.
Great, thank you for that. It seems like the more the word is getting out into the community, kind of the deeper it goes, and it kind of morphs around and increasing the number of folks. So that's what we'll continue to hope for. So Donna, I want to ask you, what could the future of diversion in Cuyahoga County look like? We've now got a diversion center. It's gaining traction. What are other opportunities that are out there?
Thanks for this question, Joan. As GCC, we're people of faith and always not just interested in what is, but what can be. The Diversion Center is crucial, but we know there's many other places along the continuum to create opportunity. Co-responder teams that consist of a law enforcement officer and a mental health practitioner exist now in parts of Cleveland, but they need to be available to the rest of Cleveland and the county. We know also that some calls that come in related to mental illness or addiction don't need law enforcement involvement necessarily. They could be handled by a care response team consisting of a paramedic and a mental health professional. We've seen these programs achieve success in places like Eugene, Oregon, and Denver, Colorado, where the STAR program has not only successfully diverted people and kept them out of jail, it's actually been shown to reduce serious crime by 34%. We know that the president of county council has actually been out in front of this, and we're hoping to see this come to fruition. And finally, this county is really in need of a youth diversion center, someplace where youth can go when they are not appropriate for the diversion center or the juvenile justice center. To be clear, youth have very different needs from adults, and we would advocate for a facility and programming that is designed for their specific needs. So all of those things are really crucial, and we believe that Cuyahoga County can continue to take the lead in the state to create these kinds of cutting edge programs for diversion, just as they led in creating the first diversion center in the state of Ohio.
Thanks, Donna. Lots of good opportunities for not only the county, but the city as well. When we think about all of these various options that are out there, and when we think about some of the ARPA funding that's come down, infrastructure and others, there's just enormous opportunity in this space. And that's an exciting thing to say, right? We can really make some investments that make a difference in the lives of people. So Brandy, on that point, this has been a hallmark initiative for the Budish administration. And thanks to all of you for this. So how do we as advocates and we as community members make sure that this diversion center continues under the new administration? We're going to have a new administration soon. So how do we make sure this thing continues, and that we can lean into some of the opportunities that Donna just lifted up, supporting care response teams and other kinds of things, our response for youth? What's your advice on how we keep current and future things going?
Yeah, thank you for the question. So very true. And you know what Donna said, I echo. We started off and all of us worked together and put this diversion center in place, but these opportunities moving forward for continuing to expand diversion, meaning different intercept points, different opportunities. So we are continuing to look at those opportunities, but with the new administration having a diversion board and also community members that's going to continue to prioritize this. This really was a priority of Executive Budish administration. And my hope is that this priority will be one of those few that continue with the next administration, just because of the support and the need. We have to continue to work with law enforcement, continue to expand their use of the center, but also let the new executive coming in know how important this is, and that this is not just a pet project by any means. This is something that needs to be part of Cuyahoga County now and moving forward, and stay ingrained in the needs that we have. It's so critical. Things like juvenile diversion that Donna mentioned. I actually just left a meeting. We, over the last few months, are starting to look at those very needs and what we can do and how we can take some of our diversion opportunities and things we've learned. But as she said, it's a very different, it's not something by any means that's the same programming as we're doing currently. But we want to make sure that we're hopefully moving forward and getting even the discussion around juvenile diversion to a point where when a new administration comes in, if none of us are here, then at least it's far enough along that it doesn't get just kicked off the table. And I don't foresee that happening. I think regardless who the new executive is, that my hope would be they would prioritize something like this. We have all of you that continues to advocate for it, even if we're potentially not here. But my hope is that this is something that we will all work to make sure the new administration prioritizes it just as the current.
Thanks, Brandy. Good advice for all of us. And I think all of us that are on this call hopefully will be devoted to ensuring the continuation of the diversion center and the expansion of the various opportunities that are out there. So thank you to our panel. We now want to flip to a Q&A session. I see Will just popped on. So we'll flip to a Q&A session. I know there have been a number of questions that have been put into the chat. Please continue to do so. Will, I've caught a couple of them and can go ahead and ask if that's okay. And then I'm sure I'll miss some as well. The other thing I wanted to, and Dr. Testa, maybe you can confirm this or I can go offline. I know you dropped the phone number, Mike, into the chat. I think you had it as 216-263-6888. I think it's actually 216-623-6888. So the two numbers were transposed.
That is correct.
Okay.
That's the number to access Frontline.
Okay, that's great. That's great. That's what happens when we're talking and texting and typing and everything else. So, All right, so let me ask the first question. This came up when we were talking about the Diversion Center, kind of the logistics, what it looks like, and also the services. Someone raised the excellent question of, are there peer support services in the Diversion Center? Mike or Dr. Testa, do you want to field that?
Yes, we do have peer support staff as part of the team at the Diversion Center. They, in fact, one of the bigger roles for peer supporters are to come out and meet with clients shortly after they arrive. They also are responsible in a lot of cases for transporting clients at the Diversion Center to various meetings. I mean, they can link them to services if a client needs to go out for some reason, to pick up something, to file for something. That recovery coach, that peer support person, is the one that generally accompanies them with that. They also facilitate meetings with various community agencies like NAMI, like NORA, who all come into the Diversion Center to introduce their services to the clients in the building too. Those groups are facilitated through our peer support staff. I don't know, Meg, if you have something to add to that.
One
No,
question.
I don't have much to add, only that I'll say that the peer support are wonderful. And I think that's one reason why this staff, I will say that I've never worked somewhere where they did trauma-informed care so well. And I think it's because of the strength of the recovery coaches. It's just a really, the concentration, I guess, of them among the staff is high. And I think that is part of what works so well.
And just to kind of table set with both of you, when we say peer support, who are the peers? Like, what does that mean?
Go ahead, Doc.
It means that they have a shared experience. They've walked the path of the person that we're serving. And that's something that no one else can bring to the table.
Yes.
Great, thank you for that, appreciate it. One of the other questions, and I'm gonna summarize kind of, it was a lengthier question. Let's see if I can kind of truncate it down a little bit, was how does the Diversion Center work with kind of the bigger external community, so that larger human services network, whether it would be, I would throw out examples like the housing community and the food community and children's services, the bigger community, how when they have someone at the Diversion Center, are they interfacing with the bigger community supports? What does that look like?
And they do on a regular basis, because a lot of these clients have issues with housing, work issues, those kinds of things, all those kinds of things. But that's what the peer support staff, as well as the BHS staff, work with them on. In a lot of cases, it's a matter of transporting people to a service provider, whether it be Job and Family Services. There are resources out there where we transport people to help them get their IDs initially. We have what we call enrollment specialists that enroll this population into Medicaid so that they have ongoing access to health services. We are part of the Unite Ohio network, which is a network that's being put together through Cleveland Clinic and Metro to link all kinds of service providers, whether it be food, housing, all of those things through a single platform, so we can link our clients electronically to a lot of those services, schedule a referral, and get them over to those services. So we do that work. We partner with agencies like the centers, a lot of the new initiatives that you see with behavioral health providers. We generally will talk with them, find out how their service, what their new service delivery is, and how our Diversion Center can interface with them. And so we're always on the lookout for those providers in the community, what they do, and how we can be a resource to them, and vice versa.
Yeah, and the only thing I'll add is it's always with the person's consent. It's always with the client's consent. So we will say to them, like, we think you could benefit probably from this program, or we'd like to link you with this individual. Do you want that? Do you want us to link you with that person? And if they say yes, we'll have them sign a release, and then we'll link them up and we'll start facilitating those conversations. Even if someone's referred by a probation officer, we ask the client, we would like to coordinate care with your probation officer. Is that okay with you? If they say yes, they'll sign a release and we'll work with that PO. But everything is with the client's consent. We're totally voluntary, and we really will offer these services to the individual. And if they want that, then we'll facilitate that linkage.
Thank you. Thank you. Appreciate that. Couple of other questions I saw. One was, can a judge refer someone to the diversion center? And then the second question is, and I'll let anybody answer these. Another question was, what's the follow-up look like? So when somebody leaves the diversion center, they're connected with an agency, let's say the agency that they had seen before. Who follows up with that agency to make sure the person actually showed up for appointments? What's that follow-up look like? So first of all, can a judge refer? Second, what's follow-up look like?
Want to go, Doc, or you take the judge and I'll take the follow-up, and we can.
Sure, yes, that would be awesome. I could take the judge and you could take the follow-up. Judges can refer. So really, I think the message is anyone can refer, as long as you're working with the person and the person wants it. Because we have had a couple situations where the provider really wants the person to go. In Frontline, they'll make the call to Frontline. This just happened a few weeks ago. Provider makes the call to Frontline, and they're like, I really want my client to go. And then Frontline says, we need to hear from the client too. So they get them on the three-way, and this client's saying he doesn't want to go, and he doesn't want to go, he doesn't want care. So it's really, as long as the person wants to go themselves, and as long as a judge will understand, I know you guys judges can order a lot and you can make a lot happen, because you order it and it happens, but you could order someone to come to us, but you've got to understand that we're voluntary. And so you could order them to do that, and then they could walk out. So you got to feel comfortable knowing that you put your best recommendation, and you could even order the person to come to us, but just know that they can walk out, and we're voluntary. So, and we have had some judges order people to come, or encourage people to come, or help people come. It's just that as a judge, it's important to understand the limits of our facility. We really can't, we're just not designed to hold anyone. So as long as you're comfortable with that, we're cool with it. We're going to work with them the best that we can.
And as far as the follow-up, and Brandy, you may want to help me out with this, we are required to, whenever we refer a person to a community agency, we keep a record of who we referred, what agency we referred them to, and we provide that information to the Adams Board and to the county so that they have a record of that. And I do know routinely there are efforts to follow up with those agencies to try to find out, did the person go into treatment there? And if possible, what was the outcome? And I don't know, Brandy, if you want to elaborate a little bit on that.
Sure. When we started this program, that's a big piece of it. We want to make sure that things are working, that recidivism numbers are going down for the jail, that people are hopefully, staying once they leave the diversion center. As Dr. Testa said, it's a short, acute center there. So, up to 9 days, that they are hopefully engaging with the other services that we either took them to or that we offered to them and provided them. So kind of that aftercare piece is huge. What we realized since opening is really how large, and it becomes a case management service almost. And so we've had lots of discussions and some follow-up, as Mike said, with Oriana. The county asked for some of that detail from Adams. It's difficult because those knowing of people, completing, their time somewhere, does that mean that the recidivism rates, for data informed decisions, it's difficult because everybody's different. They might be going to a group home that works for them or that doesn't. And so, putting a time or, 90 days on, where they go to, doesn't necessarily say if they got continued with the treatment they needed or didn't. So we're working through that process now. We are hopefully adding a number of individuals, hopefully, that can help work through some of that kind of case management piece that wasn't so much part of this effort at the beginning, but is really critical. You know, you can give them services while they're at the diversion center, but that continued follow-up and such is something that we would really like to see and kind of further expand. So that's something that we've continued to talk about and kind of focus on since after we got up and running and those things in place.
Thanks, Brandy. Your response prompts a lot of questions for me regarding data, right? You raised data. And what we're tracking and how we're looking at it. Are we tracking things like whether someone is homeless or were they in a residential situation before they presented to the diversion center? Are we tracking things like race and ethnicity? Are we tracking prior service in the military, gender, age? Are we tracking all of that stuff so that a year and a half from now we can see kind of where we are and where we've come?
Thank you for the question. When we first contracted the county with Adams Board, exactly some of the pieces you're exactly talking about are requirements on the front end we wanted to make sure happened. And as you know, Joan, so thank you for the question. These are exactly this data, the county, so I receive it monthly from the Adams Board on behalf of Frontline, Oriana, regarding patients, but not names by any means. These are not identified data. But that's really a function of the board. So we have this wonderful diversion board, and a lot of you that are on this panel are part of that board. And so really making decisions and recommendations on how we move forward as a diversion program can be informed with some of this data, for exactly like what you said, is the person homeless? Is the person, are there, certain days or times that they're coming in, or certain types or certain zip codes? So many of those kind of metrics and that you laid out, and so many more. We from the very beginning tracked, and we continue to add more and more so that we are making good decisions as we move forward as a group.
Thanks, Brandy. That's helpful, and it will be helpful moving forward. And I think it would also be really informative for other projects around the state. So we know projects are being considered, crisis centers are being looked at and developed in Lorain County. We know in Franklin County, we know. So Mike, my question would be to you, we've learned a lot over the past, 2 years or so, planning stages until now, even further back than that. Are other entities around the state that are involved in crisis planning, are they reaching out to you? You're such a rich pool, and you, Brandy, too, and Donna with your history, and Dr. Testa. I mean, everybody, there's so much knowledge. Not only, I will say, as a member of the Diversion Center board, what we've done well, but we know where we've had challenges too, and where we've kind of stepped in it. And for me, that's always the most valuable thing to share, where we or I screwed up to help save someone else in the future. So Mike or Brandy or anybody, are folks reaching out to you and saying, hey, we'd like to learn about your diversion center? Can we chat? Are they availing themselves of your expertise, Mike?
I will tell you, Scott Osecki, the executive director of the Adams Board, invited me to attend the opiate conference in Columbus a few weeks ago. And Scott and I actually did a presentation on the Diversion Center, very well attended. A number of those areas, the Lorain, Medina, staff were there, the staff from Hamilton County that are all working on, and Franklin County that are all working on various variations of a diversion center. They were all there. It was so the answer is yes, there is a lot of interest in it. What we've done here, the lessons we've learned, and we did exactly that, Joan. We shared the challenges. We shared, the challenges we had getting the OMA certification for Diversion Center because there were no standards for a diversion center in the state of Ohio. So going through that process. So a lot of those lessons we have shared and will continue to share.
If can I just quickly add to that? So thank you for saying that, Mike, and the same here at the county and probably with all the panelists. You know, situations like what we're doing right now, you know, getting the word out more and continuing to share. It happens all the time. I just did a presentation for Lake County for their government, so getting the word out, but also, you know, when we started this process, the state Adams Board really talked about, you know, moving forward, working with us as a model moving forward. So some of those challenges as these continue to pop up in other counties in Ohio, that this doesn't happen. So moving forward, that's what, you know, the Adams Board and the county and all of us will work with, you know, putting together maybe a template or working with Adams Board on those are the requirements that make more sense so that they're specific to diversion centers, because us being the first ones, they weren't specific. We kind of had to put a round hole in a box or whatever it is. So, you know, we're going to continue to work with them so that hopefully it'll be a little bit easier for everybody else, but maybe there's opportunities for standardization and lessons learned that we can help out for the rest of the state and opportunities.
Thanks, Brandy. I want to thank all of our panelists for your time today, for your expertise, for your commitment to keeping people out of jail. Just thank you for all the work that you're doing. We appreciate all of you. So thank you. I'm going to quickly flip it over to Will, who's going to close us out. Will?
Thank you so much, Joan, and thank you to our panelists. I've learned a great deal, and I know other people in the audience have been messaging and posting saying that they appreciated this information. So I want to first thank our moderator, Joan Englund, and all of our panelists, Donna Weinberger, Mike Randle, Dr. Megan Testa, and Brandy Carney. Thank you all for being a part of this very important conversation. I also want to thank the Community Solutions team and our staff for their work in helping to put this panel together. I really appreciate it. And finally, I want to thank all of you, the audience, for attending this very important conversation. As I said, this is not the end. This is just the beginning. And just listening to the conversation, I think that there is definitely opportunity for follow-up and additional information, additional conversation. And so I really appreciate this, this initial conversation on this very important topic. So on behalf of the Center for Community Solutions, again, I want to thank everyone for attending today's conversation. We encourage you to check out the Center for Community Solutions website for a copy of this recording, which will be posted later on this week, as well as the latest on health policies at the local, county, state, and federal level in this rapidly shifting health policy environment. We want to thank all of you, and we wish you all a safe, happy, and healthy holiday weekend. Thank you so much, and we hope to see you again soon. Have a great afternoon.